Okay, so how's everybody doing? Okay? So, yes, tree of knowledge. There we go. So what I'm going to be talking to you about in this second talk is the longer-term management for ankle injuries. And I'm going to be specifically talking about ankle sprains, so grade 1, grade 2, grade 3 ankle sprains. Nothing to do with any bony involvement, so this is just ankle sprains. I need to make that very clear from the earlier talks to make the distinction. So obviously the big challenge we have is people with chronic ankle instability, CAI, which I was describing earlier. So our ankle brace, if we look at our ankle brace, is designed to stabilize the ankle before or after an injury. These have been reported to assist with preventing the recurrent lateral ankle sprains. But where is the evidence for this? Is there evidence for this? We have different types of ankle brace that we will come across in the various brochures that you'll see, which are soft braces, semi-rigid braces, or even more rigid braces, laced up braces and hinged braces. So here are a few different examples of some of the ankle braces that you might see, you might come across. So what are the hypothesized effects? I always like to focus on what the hypothesis is and then see whether there's evidence to support or reject the hypothesis. So the hypotheses are that you're going to get a decreased range of motion. Now, don't forget, we're going to have too much range of motion if the ankle is unstable. So we're trying to bring the ankle back to almost like a normal range by decreasing the range of motion, providing that mechanical stability, improving neuromuscular control, improve the grounding and pre-positioning of the foot, and also to have that proprioceptive involvement to improve the movement control, motor control. So this is really where we want to start from. But now what we're going to do is take a little bit of a journey through time and look at some of the testing and some of the things that's been done over the years. Now, around 2000, these devices were really popular. These are called trapdoors. So you stand there, or get your participant to stand there, and then basically you pull a piece of string, and it then completely at random will collapse the foot into this position or this position. Now this is within the range that would not cause an injury, because what we're actually wanting to do here is look at the neuromuscular delay. You can see some EMG, early EMG system there and also on here. So what we're looking at here is what the range of motion is and also what the neuromuscular delay is. Now, I don't like trapdoor testing. I don't think it is functional, but there's been a lot of evidence out there using it, so I'm still going to tell you about some of the results. One of the review articles on all of the trapdoor testing was by a chap called Brent Arnold, and I've had the great pleasure of doing a lot of talks with Brent over the years, and one of his collaborators, Carrie Doherty. So here's our ankle joint. And what we want to know is whether or not we are able to reduce, with trapdoor testing, the range of motion of the ankle joint in the coronal plane. So we start off with our normal range of motion, which is part of the normal range for trapdoor testing, which is between 23 and 30 degrees for that trapdoor. But what happens when we try bracing? And I'm also going to mention taping. So what happens with bracing and taping? Well, with bracing and taping, we are, from this review article, we can reduce the range of motion between 43 to 58%. So in essence, we're reducing the coronal plane range of motion. Now, the thing that's quite interesting, and it is a very topical question, is then if you go and play some sport, or if you go and exercise, what happens then? Does that effect go away with the taping or bracing, or does it remain? So post-exercise, we still get between 48 to 88% of the total range of motion. So we're still stopping or preventing that end range motion, which you could argue is when the injuries are going to occur. So this is part of the evidence base to show that we are able to restrict, with taping and bracing, the range of motion, and that still works after somebody has been exercising. It doesn't wear off. It doesn't, you don't loosen the brace so much it has no effect. So I'm now going to fast forward quite a few years, because that was back in around about 2002, 2003. So we're now going to 2014. The effect of soft and semi-rigid orthoses on star excursion balance test. Now, you've seen pictures of the star excursion balance test in the earlier talks. Here it is. Here's the star excursion balance test, which we now reduce to being a Y balance test in the majority of our work. We don't need to do the full star excursion. We just have a reduced Y balance test. So when we use a Y balance test or star excursion balance test, what we see is we get a 10% increase in the reach distance when wearing an ankle brace. This would imply that the person is able to do more and be as stable. If you have a soft orthosis, soft ankle brace, we get a 13% increase. No significant difference between the semi-rigid and the soft brace. But we are seeing both of these are having a pronounced effect. Now, when you see an effect greater than 10%, we start to get excited, because 10% is worth having. If you see a significant difference and it's only a 1% change, and you go to your patient, hey, I can make you 1% better. Where are you going? Okay, 1% is not worth having. 10% is worth having. So when we see a 10% change, with us also statistically significant, that's when we start to get exciting. So what we are seeing here is that we get an effect with dynamic movement, albeit a dynamic balance test. Okay, 2019, still trapdoors still appearing in the literature. This work was looking at the effect of ankle bracing in a simulated sprain drop landing. So again, as I say, is one of these trapdoor tests. Sagittal plane kinematics appear to be unaffected during the single leg landing, simulated single leg landing, when you're using a brace. So we're not affecting the sagittal plane. But the sagittal plane is not really the problem, it's the coronal plane. But when we consider what's going on with the coronal plane, we get showed a lower inversion angle when we are using the ankle brace. So again, more evidence, more recent evidence to show that yes, we are still getting these reduced ranges of motion. So the conclusions for, in essence, a lot of this trapdoor testing is that active bracing reduces inversion angles due to sudden ankle inversion compared to unbraced or passive placebo conditions. So we are having this effect. Okay, it's always worth looking at systematic reviews. So this systematic review was purely on dynamic balance measurements in healthy and chronic ankle instability. So when we then look at all of this literature, the ankle braces effect with the star excursion balance test or Y balance test measures in healthy individuals and chronic ankle instability subgroup patients. And we get a strong positive effect with the chronic ankle instability group, which indicates that we get a significantly greater effect on dynamic balance, improvements in dynamic balance, if you will, when wearing a brace compared to no brace. Interestingly, that what's come out of this systematic review, we support a strong effect in people with chronic ankle instability, but little to no effect in healthy participants. So that's worth knowing. That would indicate that if you've got an ankle injury and you've got chronic ankle instability, bracing might be a good thing for you to do. if you haven't ever had an injury, it probably isn't going to do anything. But this is just looking at the kinematics, not the injury rate or injury risk, which we will come on to shortly. Now, one of my problems with all of this work is standing on a box with the box dropping down or doing a standing balance test is not functional. Despite us thinking it might be functional, it's not. I'm sorry. Standing on one leg is not going to predict when you're going to die. It's just nonsense. So let's look at a proper functional activity. And what I'm about to show you is a very sensible activity. So this is one of the Welsh number 9 here, beating around about 7 English people to the line. I've got to watch that again. There we go. I'm Welsh, by the way. I'm not English. So there we go. So the Welsh are far superior with rugby than the English. But, you know, let's focus on something that we don't know. So what we have here is a dynamic challenge with the way he's done side cutting. So we need to have side cutting maneuvers and dynamic challenges. So what we wanted to do with some of our work is we wanted to test an ankle brace with running, with a T-drill cutting maneuver, so doing a 60-degree cutting maneuver, and also hopping. And we wanted to know whether or not this ankle brace was able to detect any differences in the 3D movement of the rear foot to the tibia. Now, I'm not going to go into too much detail about the model, but can you see that the foot is 3 different colors? The 3 different colors means we are tracking each part of the foot independent to the other. This is a multiple segment foot, 6 degrees of freedom model, if you like your biomechanics. So what we're wanting to know is what the purple bit is doing relative to the tibia, because that's the bit that we're interested in with the role of the ankle bracing. So this is a 3-segment foot model. So what we're able to do now, when looking at the brace and the no brace condition with the cutting maneuver, is we're able to isolate what is sagittal, coronal, and transverse plane. So sagittal plane, we get a little bit of a reduction with the use of the brace. The coronal and transverse planes, we get around about a 25% reduction in the range of motion. So during dynamic activities of sprinting and side cutting, we are still seeing this reduction in the end range of motion. So let's think about that twisting and turning, the transverse plane and the coronal plane. This is where the injuries occur. Same with the hopping task. So we're wanting to know what the dynamic movement is between there and there with this landing. So again, it's a dynamic task which is more sport specific than standing on a box and somebody tugging a piece of string. And what do we see with this? Well, once again, we see around about a 25% reduction in the range of motion in the coronal and the transverse planes. So let's think about this. The transverse plane range of motion is being reduced. This is largely happening before contact, before the foot hits the ground. And now what we're going to do is think about these reductions in movement and think about these two things again. Oh, let's go there. So would it affect that one, or would it have affected this one? I think an ankle brace here would have probably not solved the problem. An ankle brace with this one, with the internal rotation pre-contact, I think an ankle brace would have saved that injury. So it's a question of the mechanics now related to the injury mechanism of whether we can perhaps reduce the risk of injury. So that's all biomechanics. It's not reality. It's not to do with whether or not injuries have or haven't occurred. So let's look at what the evidence base is in terms of the incidence and prevention of injury. So let's look at this. So ankle braces are frequently worn by individuals who take part in sporting activities. Okay, we know this. Now, is this just to protect an existing injury, or can this help people who have not got an injury yet? Can we use it prophylactically? So what we're trying to do, of course, is improve stability and obviously reduce pain if you have chronic ankle instability. But can these prevent a first-time injury, or is it just recurrent injury? Where does the evidence stand on that? Well, there was a fantastic paper written in 1994. Old does not mean obsolete, as I keep telling my children. And we have here a paper that was published in the American Journal of Sports Medicine, and this was on 500 top-level soccer players in South Africa. And those with a previous history of injury, there was no difference here in the odds ratios, if you will, between these support and no support. In essence, wearing an ankle brace or not wearing an ankle brace made no effect if the person hadn't previously had an injury. So there's no point in wearing an ankle brace if you haven't had an injury. Important. Make sure they don't sell you one if you haven't had an injury. We're watching. So we can get this effect from semi-rigid orthoses. Now we're going to fast forward to a little bit further on, so 20 years later, and we get the relative risk of recurrent ankle sprains in a bracing group versus a training group was reduced by 47%. Now this is a comparison of neuromuscular training versus bracing. So this is showing that the bracing is having a much greater effect at reducing the chance of a recurrent injury. Twofold change, 47%. There was no significant difference in the severity of the ankle sprains. So in essence, it didn't change the severity of the injury, but it did reduce the incidence. So it's very important that we unpick these things. What is severity and what is incidence? So wearing an ankle brace will reduce the incidence, but not necessarily the severity. So bracing was superior to neuromuscular training in reducing the incidence, but not the severity of self-reported ankle injuries, ankle sprains. So again, further evidence to suggest that if we have previously had an ankle injury and we're at risk of another ankle injury, wearing a brace is a very, very sensible thing to do. What about cost effectiveness? Because that's a really important aspect in all walks of life, and it's becoming more and more relevant in the world today. When we're looking at the cost effectiveness of neuromuscular training versus bracing, bracing in euros was significantly less than neuromuscular training, and obviously significantly less than a combination of the two. So this is an effective way of immediately reducing your risk of re-injury, which is cost effective. Now, cost effectiveness versus ethics of intervention is an interesting conversation of what is best. But if it's a cost-centered problem that you have, then bracing is actually a very cost-effective way of reducing the number of re-injuries. Okay, so now we're going to delve back into the systematic reviews again. It's always worth looking at the systematic reviews in this area. And one lady that's done an awful lot of work is Helen Handel on this. Now, Helen's work she's very good at systematic reviews, very good at interrogating the literature. So if you're interested in anything to do with sports medicine and sports injuries, Helen Handel has done a systematic review on pretty much everything. So she's worth looking up. So there's good evidence for the beneficial effect of ankle supports in the form of semi-rigid orthoses or Aircast braces to prevent ankle sprains during high-risk activities e.g. soccer and basketball. This systematic review is Cochrane Review Library, and every 10 years or so, the Cochrane Review has to renew it renews the papers in essence and re-looks at all the literature. Participants with a history of previous sprain can be advised wearing such supports may reduce future risk of injury. So this was originally written in 2001, updated in 2011, and is highly likely to be updated any time soon, if Helen hasn't retired yet. So it gives you some idea of the fact that this is a Cochrane review, very, very intensely reviewed, Cochrane reviews, very hard to get a Cochrane review. Also in the Cochrane Library, device, chronic ankle instability is a common after acute lateral ankle sprains. Initial treatment is conservative, either with bracing or neuromuscular training. So neuromuscular training is effective. It's just not as cost effective as bracing according to the previous systematic review. If a symptom persists and ligaments on the outside of the ankle are elongated or torn, surgery is then considered. So surgery comes much further down the line with the management of ankle sprains. Emphasis on sprain. Okay, one of the questions that I sometimes get is, what about the effect on performance? You give an ankle brace to an athlete, they go, oh, that's going to slow me down. Does it? Where's the literature on that? Well, the literature would suggest there's no effect on vertical jump height. There's no effect on isokinetic strength. There's a 1% decrease in sprint speed. Now, if you're Usain Bolt, you don't care. If you're chasing Usain Bolt, you'll blame the brace. Okay. 1% is not, okay, you could argue that that's going to have some effect. But this is the interesting one. Improvements in shuttle run times. So if you are doing a sporting task where you have rapid changes of direction, your performance will increase wearing an ankle brace, not decrease. Why? The transition of you going from one direction to another is faster because your ankle is more stable. You have less range of motion that you're moving through. Therefore, speed, time, distance, okay, you get a faster turnaround. If we look at this in more detail, this particular paper that defined this, we're not talking about large percentages here, but it was significant. So on 2 different test sessions, without the brace was 9.63 seconds for this shuttle run time, and it was 9.5 seconds, and then 9.5 to 9.35. So there's a little bit of a training effect there. But regardless of training effect, the ankle brace still reduced on both occasions the shuttle run time. Now, whether or not that's really clinically important is questionable, but it's statistically significant. So we'll let it stand as it is, that performance with change of direction is not worse. And arguably, it is marginally better when wearing an ankle brace. One of the things I wanted to put in here, because I haven't really got an awful lot of literature on this myself, but one of the things I wanted to bring in here, because you're going to see it in a moment in the workshop, is neuromuscular electrical stimulation. And there is certainly some evidence out there to suggest that facilitation of spinal excitability using neuromuscular electrical stimulation and exercise. Neuromuscular electrical stimulation, zapping somebody when they're sitting there passively, not sure about that. If you're doing a functional or movement task, when you combine it with a movement task, you are then training the brain and the muscles to get the maximum that the muscles can be recruited, the most motor units recruited, while still involving the central nervous system when you're doing this as an active exercise with neuromuscular electrical stimulation. And I think you'll be playing with that in a bit. So any neuromuscular electrical stimulation superimposed onto isometric voluntary contractions can provide an effective neuromuscular stimulus for training, which can be used in early management, early training, recovery of people with ankle instability. So what we have here is a situation where the person is doing a standing balance test with and without the NMES on. So you can see with it on, more stable, and when they're not got it on, they're less stable. So we get improvements in stability because we're getting that better recruitment, in this case of peroneus longus. It's very, very important when you're looking at your protocols for neuromuscular electrical stimulation to make sure the parameters are right and the protocols are right. Just sticking on NMES and zapping your patient with whatever setting you think is not the right way of doing it. You have to make sure that you're using proper protocols which are well defined in the literature. So make sure that you do that. So in conclusion, ankle bracing can have a significant stabilizing effect in the coronal and transverse planes. These in turn provide a mechanical and proprioceptive input to improve dynamic stability. And these will reduce the risk of injury if you have previously had an injury, but they will not be any use if you've not had a previous injury. So ankle bracing should be advised to prevent re-injury during high-risk sporting activities. Ankle bracing and neuromuscular electrical stimulation can improve neuromuscular control. And this goes for these 4 points of treatment. We're wanting to reduce pain associated with chronic ankle instability. We're trying to do this by reducing or changing the alignment, by changing the position, or at least the range of motion that somebody is moving in, the dynamic alignment, if you will. This will improve their dynamic stability. And also with the neuromuscular electrical stimulation, you're also going to be improving the strength, the motor unit recruitment of those muscles to make sure that they are available, the motor units are available when the athlete is needing them to control the ankle. And I will leave you with one thing, one proverb. This is from Brent Arnold, who, as I mentioned earlier, Brent has helped me with a number of things. He's now at Indiana University. And I'll just read this. May God turn the hearts of our enemies, and if he cannot turn their hearts, may he turn their ankles, so we will know them by their limping. Thank you so much. Any questions? I will be on the workshop as well, so you can ask me questions then. So Jenny, do you want to put the G-Rock slide up? Is that what's happening next? Okay. Apparently I'm doing this bit. I have to point out, I am not being paid for this, you know. Okay, so one of the things that we use all the time in our research, because quite often, you know, you think, oh, research is going to take ages to do. We use what we refer to as the Global Rate of Change Scale, the G-ROC. And what we do, after an intervention, we will ask the individual to tell us, in this case, how their stability has changed. You could put anything in here, stability, pain, function, but for this, we're going to use stability. So as a result of the intervention, and this could be an immediate effect, it could be an effect over 2 weeks or 4 weeks. You ask, how was your stability change? Was it much improved? Through to much worse. And in the middle is no change. When we are scoring this, if somebody scores 2 or above, it means that there has been a clinically important change in that individual stability. Equally, if it's -2 or below, that's also a clinically important change in stability, only that you've made them worse. So this takes seconds. We have been collecting data using this across a large number of individuals. The assessment is one question. Incorporating this into your clinical practice to determine whether or not you have made any difference to that individual is so easy to do. And that's what we're going to be doing now in the workshops, because each of the stations, each of the 3 stations, we have interventions that are meant to be doing something to this. And what we want to know is how you perceive your change before and after the intervention, or before and during the intervention, to see whether or not you perceive the change as being meaningful. Okay? Very simple, very effective. It's evidence-based. It's not research, but it's evidence-based, clinical evidence-based. Okay, is that enough?